Welcome to our sonography lecture on renal pathology, part 3 of 14, renal cysts and cystic diseases for the sonographer. This lecture will cover renal cysts, von Hippel-Lindau, tuberous sclerosis, acquired cystic kidney diseases, polycystic kidney disease, autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease, multicystic dysplastic kidney, medullary sponge kidney, medullary cystic kidney disease, and nephronophthosis. So what are renal cysts? Renal cysts are going to be in varying locations and appearances that arise from the kidneys. Let's begin with the simple renal cyst. The simple renal cyst is just going to be a fluid-filled sac arising from the kidney that meets the simple cyst criteria. So thin walls, anechoic through transmission. We can see these with multiple diseases, as we're going to talk about shortly, or they can just arise, which means they're idiopathic. Acquired cysts, which are typically going to show up later in life, are thought to be due to obstructed tubules within the nephron. We can also be born with cysts, or we can inherit cysts. Now, the location of the simple renal cyst varies. It can arise from the cortex, the medulla, or the renal sinus, and some are considered exophytic. And an exophytic cyst is when it's just kind of like on the very periphery of the kidney, almost seems to be floating out next to the kidney. Renal cysts are very common. In fact, 50% of people over the age of 50 have cysts, and most of them don't even know it. Pediatric patients, however, should not have cysts, and if they do, they're a little bit more concerning for cancer. Now, clinically, simple renal cysts are typically asymptomatic. However, they can become a little bit more symptomatic if the cyst becomes very large and starts compressing on things, if there's hemorrhage or calcifications within, or if the cyst becomes infected. However, most of the time we are going to find these simple renal cysts as incidental findings. The patient's in for workup for a different symptom. We happen to see them on their ultrasound. Now, as far as appearance goes, again, we're going to meet that simple cyst criteria, anechoic, thin walls through transmission. The cysts might be single or multiple. They might only be on one side, or they can be on both sides. And we want to use color to prove that there's no internal flow. In this first example here, we have the simple renal cyst sitting more within the corticomedullary border, and we're using color flow then to show that there is no flow within the cystic structure. Here's another example of a simple renal cyst. This one's a little bit larger. We can see again that it's anechoic, arising from the cortex of the kidney. Here's another example of a little bit more of an exophytic cyst. We have the renal cyst next to the kidney. Again, it's showing thin walls, anechoic, and through transmission. Next up, we'll talk about the complex renal cyst. Now, the complex renal cyst is again going to be a fluid-filled sac, but now it does not meet the simple cyst criteria. And we talked a lot about this during our discussion on the Bosniak scale. So when we see a complex renal cyst, we do need to consider it malignant until we prove otherwise. Remember, any irregularities of the wall or of the septa or any solid components increase the likelihood of malignancy. So on ultrasound then, the complex renal cyst is going to have septations or in thick walls. We'll see calcifications either along the walls or along the septa. We might see some internal echoes or solid components within. And then the septa or the walls might also show increased vascularity. So here we have an example of a complex renal cyst. We have very irregular walls here. We can see the septa coming off of here, kind of. And again, those irregular, kind of lumpy, bumpy walls. We no longer have that nice, smooth oval shape. Here's another example of a complex renal cyst. This is the cystic area here. Color, however, is on with this one, so we can see that there's increased vascularity along the periphery and even into some of the septa. Next up, then, we have renal sinus parapelvic cysts. Now, renal sinus parapelvic cysts are going to be cysts that originate at the renal sinus. So these are going to be closer to the urinary collecting system. These are thought to arise from lymph vessels within the area, and they become dilated, filled with lymph fluid, therefore appearing like a cyst. So the renal sinus parapelvic cysts should not communicate with the collecting system. And these are very easy to confuse with extrarenal pelvises. If you recall back to our congenital variants, an extrarenal pelvis is kind of a floppy, squishy pelvis that sits outside of the kidney and tends to collect urine before it exits into the ureter. The renal sinus parapelvic cyst is holding on to lymph fluid, kind of also in the same area, but it does not communicate with the collecting system. So we shouldn't see any change if the person goes to the bathroom or changes position. That cyst should always remain consistent. Clinically, again, these cysts are going to be asymptomatic unless they become large enough to hemorrhage or cause an obstruction. Now, as these renal sinus parapelvic cysts enlarge, and because they're at the sinus, what they're going to start to do is compress upon the ureter. That can make fluid back up into the kidney, or they might compress against the artery, which can cause some issues with blood flow into the kidney, therefore increasing blood pressure in the body. So ultrasound-wise, then we're going to see a cystic structure sitting at the pelvis, and again, we need to make sure that it does not communicate with the collecting system. And so here we have an example of our parapelvic cyst. We can see the kidney here. And we have our parapelvic cyst at the pelvis. And this one is actually causing a little bit of an obstruction, so we can see some fluid within the calyces. So again, these parapelvic cysts should not communicate with the collecting system. Moving on to another subset of renal cysts, we have renal cysts that are associated with renal neoplasms. And these are going to arise more from systemic diseases that present with both cysts and solid masses in the kidneys. Our first systemic disease then is von Hippel-Lindau syndrome. So von Hippel-Lindau, or VHL, is an autosomal dominant genetic disorder that causes cysts and tumors on multiple organs. So remember that autosomal dominant means that only one parent needs to have the disease to pass it along to 50% of their children. So the children have a 50% chance of inheriting an autosomal dominant genetic disorder. Von Hippel's role in the appearance of kidneys then shows us that cysts will start to appear on the kidneys and tumors as well. Now, the tumors that show up on the kidneys are most likely going to be cancerous, and they're going to be the adenocarcinoma variant. So cysts and more likely to develop renal cancer. It goes along with von Hippel-Lindau. Tuberous sclerosis is another systemic disease that causes issues for the kidneys. Again, this is another autosomal dominant genetic disorder that causes cysts and tumors on multiple organs. Tuberous sclerosis can also cause further complications for the patient, including mental retardation and seizures. As far as the kidney goes, again, cysts and tumors are going to show up on the kidneys. The cysts will appear mostly simple. The tumors with tuberous sclerosis tend to be angiomyolipomas. Also, the cysts that show up on the kidneys are more numerous and are very difficult to differentiate from polycystic kidney disease. And our last systemic disease that is associated with kidney cysts is the acquired cystic kidney disease. Acquired cystic kidney disease shows up in patients who have been on dialysis in the long term, and we consider that to be more than 3 years. So again, cysts and tumors appear on the kidneys after use of long-term dialysis. These cysts are going to be, again, simple cysts and very numerous. The tumors that are more likely to develop are adenomas, which are benign, and then also adenocarcinomas, which are malignant. Moving on into yet another subset of renal cysts, we have polycystic renal disease. Now, polycystic renal disease is either inherited or a congenital condition that causes multiple cysts to form on the kidneys. We'll begin then with the overarching idea of the polycystic kidney disease. So polycystic kidney disease, we consider it just to be a general term for diseases that cause multiple cysts to grow on the kidneys. We often abbreviate this down to PCKD, polycystic kidney disease. So PCKD is the overarching theme for autosomal recessive polycystic kidney disease autosomal dominant polycystic kidney disease, and multicystic dysplastic kidney. Knowing that these three diseases are part of the polycystic kidney disease family, then that'll help you to remember that these present with multiple cysts on the kidneys. Starting then with autosomal recessive polycystic kidney disease, we need to remember that autosomal recessive means that it's inherited and that there's a 25% chance of passing the disease along from two parents that carry the recessive disease. So again, in other words, mom has to have the recessive gene and dad has to have the recessive gene. They might not exhibit the qualities of it, but they carry it. When they have children, then they have a 25% chance that both of those autosomal recessive genes get passed to the same child. The same child has to then have both of those autosomal recessive genes from their parents to exhibit the disease. So again, it's a 25% chance with autosomal recessive genetic disorders. What ends up happening in autosomal recessive polycystic kidney disease then, the child inherits it then from their parents, and the collecting tubules of the kidney begin to dilate, and as those begin to dilate, they do cause renal failure. Now, because this is an autosomal recessive disease, it typically presents in childhood, so it can be in the perinatal or in utero, it can be neonatal, infantile, or even juvenile. So another name for autosomal recessive is the infantile polycystic disease. Now, the way that I like to remember autosomal recessive tends to affect children more. I think of recess at school. Children go out and play. So recessive and recess reminds me that this is a more childhood disease. Now, the incidence of autosomal recessive polycystic kidney disease is actually pretty rare. It's only 1 in 20,000. There are 4 separate classifications of autosomal recessive polycystic kidney disease that we need to know. We have perinatal, which usually is diagnosed in utero and tends to end in demise. We have neonatal, infantile, and then juvenile. Perinatal and juvenile are the more common presentations of the disease. So we need to know how those look by ultrasound. So let's look clinically at what the juvenile form of ARPKD presents as. And what's interesting about the juvenile ARPKD is that it actually is going to be more liver issues that bring the child in. That'll result in imaging, and then they'll figure out that it actually is stemming from the polycystic kidney disease. So in the juvenile form, the patient is going to have signs of hypertension. So that's actually really rare for children to have high blood pressure. So that is going to be a big red flag. Their kidneys are going to start giving out. So we're going to see that via lab work. The kidneys might be quite a bit larger. So that might be something that the doctor can feel. They're also going to develop hepatic cysts. Multiple bile ducts will be present. We learned about Caroli disease, kind of goes along with this as well. And then the big one is going to be periportal fibrosis. And that periportal fibrosis causes portal hypertension, which then causes cirrhosis of the liver, splenomegaly, esophageal varices, everything that goes along with portal hypertension. So these kids are kind of in a rough spot when they start to present with liver issues. Now, as far as ultrasound goes, for the juvenile ARPKD, we are going to be able to see those large kidneys. We're going to have a very echogenic cortex and medulla, and we're going to have difficulty in differentiating the medulla from the cortex. Now, if we look beyond the kidneys, we should be able to see the hepatic fibrosis as echogenic strands that run along the portal system, and then we should also see an enlarged spleen. Now, what is tricky about how autosomal recessive polycystic kidney disease presents is that it doesn't present with visible cysts on the kidneys. So that's going to be the big underlying part for this. Autosomal recessive polycystic kidney disease creates microscopic to reaching a maximum of 1 to 2 millimeter cysts. So they are very, very tiny cysts, which makes them extremely difficult to visualize by ultrasound. So if we go back to what we see, this echogenic cortex and medulla, what we're actually seeing is the interface of all these cysts and the posterior enhancement or the through transmission, making that kidney look really bright. So we don't actually see the cyst typically on autosomal recessive. What we see is the physics of there being cysts makes the kidneys look super, super bright. So here is an example then of an autosomal recessive polycystic kidney disease kidney in a juvenile. The kidney is quite a bit bigger. It's measuring 13.8 centimeters, so that's pretty big for a kid. And we can see that it's very echogenic, and we start to lose the differentiation between the cortex and the medulla and the sinus. Everything just kind of blends together in its brightness. So again, we can see there aren't cysts like what we would expect, and that's because they're just itty bitty tiny cysts. Physics of ultrasound doesn't allow us to see 1 millimeter, 2 millimeter structures usually, unless you're using a very high frequency. And so these tiny, tiny little cysts just kind of all blend together, and all we see is the through transmission because there are so many tiny little fluid-filled pockets in there. Now let's back up into perinatal ARPKD and let's talk about what that looks like. So perinatal ARPKD is something that's going to be diagnosed on that fetal survey at the 20-week fetal survey. During that ultrasound, we'll see very large kidneys. Again, we're not going to see the cysts because they're so itty bitty, even smaller on a fetus. But what we are going to see is the result of those cysts being there, showing as echogenic cortex and medulla again. And then because the kidneys are not working well, the patient is, or the fetus, is going to have oligohydramnios, so no to low amniotic fluid. So again, autosomal recessive polycystic kidney disease does not present with visible cysts to the ultrasound eye. They are there in microscopic form. Ultrasound sees echogenic kidneys. So here's an example. We have the fetal abdomen here. This S is representing the spine, and here we are seeing enormous kidneys bilaterally. Again, we can't see the cysts in utero. We can't see the cysts in the pediatric patient. All we see are bright, large, echogenic kidneys. All right, so let's switch over then to autosomal dominant polycystic kidney disease. An autosomal dominant polycystic kidney disease, again, is an inherited disorder. Because it's autosomal dominant, that means that one parent has to be exhibiting the disease, and they have a 50% chance of passing that disease then to their children. Autosomal dominant polycystic disease comes in two variants, variant 1 and 2, and type 1 is the most common. Autosomal dominant polycystic kidney disease typically does not show up until well into adulthood, so we also refer to this as adult polycystic kidney disease. And as I told you before, I use recess and recessive to remind me of children. I think of autosomal dominant as being adult. We have AD here, we have AD in the adult. So that's how I like to remember the two. Now, clinically, these patients are going to start showing symptoms between the ages of 40 to 50. And women are typically going to have a more severe presentation. Again, it has more to do with estrogen in the body and how the cysts are forming. And unfortunately, by the age of 60, half of the patients with ADPKD are going to be in end-stage renal disease and need a transplant. If they are unable to get that transplant, it is a fatal disease. Now, one of the first signs of autosomal dominant polycystic kidney disease is going to be increased hypertension. So that maybe they're doing their physicals every year and they see a quick rise in their blood pressure. Maybe they'll notice blood in their urine, hematuria. They might also notice that they're just having more fullness in their abdomen as those cysts become plentiful. It might be painful to have all those cysts in there. They're going to start to have headaches. That's a result of the hypertension, more UTIs, and their lab work might show that their kidneys aren't working very well. So on ultrasound then, we do expect to see cysts with the autosomal dominant variant. So remember, autosomal recessive, no visible cysts, autosomal dominant, very visible cysts. So we're going to see multiple cysts spread out all over the kidneys. Those kidneys are going to be very large as well. Some of the cysts on the kidneys might show some signs of infection or hemorrhage, And then we're going to really lose a lot of that renal shape. It's just going to look like a giant cluster of cysts where the kidney should be. So this is an image of a younger man with polycystic kidney disease. Again, typically it's between 40 and 50. It can be earlier in life. But so this is a younger patient with polycystic renal disease. And we can see here, this is the right kidney. We can see multiple cysts on the kidney. And the kidney, they say, measures 15 centimeters on the right and 17 centimeters on the left. So those are very large kidneys filled with cysts. Here's another example of actually a younger person with polycystic kidney disease. Again, just tiny cysts scattered throughout the area that we would expect the kidney to be in. We don't see any true renal sinus or renal parenchyma, but what we can see is a bunch of cysts in the area. And then another close-up of a kidney just showing a bunch of cysts. So when we are imaging the patient with cysts on it, you are going to see many patients with very normal appearing kidneys, and maybe they have 1, 2, or 3 simple cysts hanging off of it. Those are simple cysts. That is not autosomal dominant polycystic kidney disease. When a patient presents with autosomal dominant polycystic disease, their kidneys are going to be large and they're going to have multiple cysts. The older they are, the more their renal parenchyma is going to be replaced by those cysts. Our last member of the polycystic kidney disease then is the multicystic dysplastic kidney. So multicystic dysplastic kidney is not inherited. This is just an idiopathic thing that can happen as a fetus develops. We are usually going to be able to see this in utero, and it is the most common cystic disease in neonates. What they think happens with multicystic dysplastic kidney is that at some point in utero, a urinary tract obstruction has occurred. So somehow the ureter was blocked, or possibly the urethra was blocked, or possibly both ureters get blocked. And because of that obstruction, the kidney gets a lot of fluid backed up into it, it dilates things, and the kidney starts to function poorly. Multicystic dysplastic kidney, because it's acquired, can be in just one kidney, or it can be in both. If it is in both kidneys, it is not compatible with life. Again, that goes back to the kidneys participating in the production of amniotic fluid. If there's not enough fluid, the lungs can't develop and the fetus usually dies. If a patient only has unilateral multicystic dysplastic kidney, then they are more than able to be born and go on to lead a very uncomplicated life. However, some complications do come along with multicystic dysplastic kidney. That includes hypertension, blood in the urine, infection of the cysts, which can result in flank pain. It also is going to increase the risk for renal malignancy ever so slightly in the kidney that is affected by the multicystic dysplastic disease. So in ultrasound, we need to take a look at how it's going to look at different stages of life. In neonates and children, what we're going to see are multiple cysts in the area that the kidney should be in. We're typically not going to see much for renal parenchyma. There's not going to be a renal sinus, and sometimes there isn't even a renal artery going to this area. As the patient ages then, the multicystic dysplastic kidney is going to start to atrophy because it's not getting blood flow, it's not being used, so it's going to start to atrophy down, get very small, and when that happens, they oftentimes become echogenic and calcified. So here we have an example of multicystic dysplastic kidney in utero images. So we have the fetus here. We can see large cysts in the area of the kidney starting to replace the renal parenchyma. On this image below, again, we have multiple cysts that we can see, a very large kidney in utero starting to replace that renal parenchyma. So multiple cysts viewed in utero. As the patient ages then, as long as this is a unilateral disease, we can see then that the kidney has become very shrunken down. It's actually difficult to even recognize this as renal parenchyma. So I want to recap the polycystic kidney diseases because it's important to recognize when do we diagnose it, what does it look like at each age, and when does it present itself. So again, autosomal recessive polycystic kidney disease. In utero, we're going to see big kidneys. There will not be any cysts. This often is going to end in demise because there's very little fluid. Those kidneys are going to be big and echogenic in utero. If it does not present in utero, but presents as a child, either in the neonatal or juvenile variant, we're again going to see very big kidneys, but we're not going to be able to see those cysts. And what we're actually going to see are more liver issues. As an adult with the ARPKD, it's 100% going to depend on what the outcome was of their treatment as a child. So the autosomal recessive part is not significant in adulthood. Moving down then to ADPKD or adult polycystic kidney disease, kidneys look normal in utero. Kidneys look normal as a child. It's when they become older as adults that those cysts are going to start to pop up and their symptoms are going to present. Multicystic kidney disease then, we are going to see a bunch of cysts and we're going to be able to see those in utero. If it's only one side, that's fine, that's compatible with life. If it's bilateral, it ends in demise, again because of oligohydramnios. If it is unilateral in the child then, again we are going to see multiple cysts replacing the kidney. And as an adult with multicystic dysplastic kidney, we are going to see a very, very tiny kidney, possibly even absent appearing, or a calcified structure in the renal fossa. Moving on to another set of cystic diseases, then we have the medullary cystic family. So medullary cystic diseases are again inherited or acquired diseases that cause cysts to form on the kidneys due to dilation of tubules within the pyramids. So remember, the medulla includes the renal pyramids. When we have a patient that presents with medullary cystic disease, we are going to be focusing on how those pyramids appear. So we'll start then with medullary sponge kidney. Medullary sponge kidney, I feel, is actually relatively common. I've seen it quite a few times in scanning. A lot of people don't even know that they have it until they start to develop stones or have some abnormal lab work for their kidneys. So medullary sponge kidney is a developmental anomaly of the pyramid. So this is typically something that they're not necessarily born with, but as they age, there's going to be more complications that arise with it. And medullary sponge kidney stems from the ducts of Bellini within the nephron. They become dilated, and those are going to appear as tiny little cysts. But what happens over time is that those tiny little cysts are actually holding on to urine. And because of the urine stasis, stones and calcifications start to form in the pyramids. Now, medullary sponge kidney, when I've seen it, has typically been bilateral, but because it's a progressive acquired disease, it can be unilateral or bilateral, and then it can be just part of the kidney or it can be all of the kidney. On ultrasound then, we're going to see very bright and echogenic pyramids. There will be thinning cortex, and sometimes we'll be able to see stones as well. So here's an example of a medullary sponge kidney. Again, the pyramids are very bright and echogenic. Remember, these are tiny little cysts within the pyramids. As the tiny little cysts hold on to urine, they're more likely to start to form stones. We can also see then that the cortex of the kidney is very thin. We want that to be over 1 centimeter. In the medullary sponge kidney, it usually is well under. Next in our medullary family, we have the medullary cystic kidney disease. Now, medullary cystic kidney disease is an inherited disorder. So medullary sponge is an acquired kind of developmental thing that happens. Medullary cystic kidney disease is inherited. And this one again is an autosomal dominant disease. Now you'll see a pattern with our autosomal dominant. It typically means that this doesn't appear until adulthood. And so that is also true then with the medullary cystic kidney disease. This is going to be a disease that typically affects older adults and it will eventually lead to renal failure. What happens is that the disease causes tiny little cysts again to form in the medulla and at the corticomedullary border. The corticomedullary border is that area between the cortex and where it meets up with the pyramids. So what ends up happening is these little dilations in the pyramids, these little cysts, are going to cause the tubules to atrophy, and eventually those tubules will become so small that they just kind of disintegrate, and what ends up resulting then is lots of scarring within the medulla. Therefore, the kidneys don't work very well anymore. So the kidneys can no longer concentrate urine when those tubules are now no longer functioning. And what ends up happening then is it leads to an imbalance of electrolytes, which typically results in the patient going into renal failure and having multiple issues with like heart stuff and liver and cognitive ability as well. So when your kidneys are failing, the whole body starts to kind of shut down as well. On ultrasound then, we're going to see bright, small, and echogenic kidneys. There might be tiny little cysts, less than 2 centimeters in the pyramids, and we're going to start to lose tissue differentiation. So we're no longer going to be able to tell really the difference between the cortex and the pyramids and the sinus. It's all going to be kind of the same brightness. So here's an example of medullary cystic kidney disease. We have the cortex out here, much brighter than what we would expect. We no longer can really see the pyramids at the corticomedullary border. What we can see are tiny little cysts in that area, and then we have a very bright sinus as well. And remember, the kidneys tend to be on the smaller side. Usually when your kidneys are no longer functioning very well, if they're not being used, they're going to shrink down. So that's another way to remember. Medullary cystic disease results in renal failure. That means we're going to have small, bright, echogenic kidneys. Now, a very similar disease to medullary cystic kidney disease is nephronophthosis. And nephronophthosis is an autosomal recessive disease. So as we've been talking, recessive diseases tend to affect children. So medullary cystic kidney disease is autosomal dominant, affects adults. Nephronophthosis is autosomal recessive and affects children. It is essentially the same issue that comes along with the adult version. It just happens in childhood. So again, tiny little cysts appear in the medulla. It causes the tubules to inflame and scar, and therefore they no longer work. So again, the kidneys cannot concentrate urine, which leads to an imbalance of electric light. Ultrasound-wise then, again, we're going to see bright, small, and echogenic kidneys with tiny cysts at the medulla with loss of tissue differentiation. These are just going to be seen in children instead of adults. And here is an example of a child with nephronophthosis. Again, we no longer can really tell the difference between the cortex, the medulla, and the sinus. It's all kind of that same bright echogenicity. The kidney is measuring smaller. We might see some small cystic structures along the corticomedullary border. And that brings us to the end of cystic diseases of the kidney. Up next, we have malignant renal neoplasms.